Recording in progress.
So, good evening, everyone. Thank you so much for joining in on this Saturday evening for No Thrombosis, which is a national workshop. We've been doing this every month, trying to gather interesting cases on thrombosis and having an interactive platform to improve stroke care outcomes. So, without further ado, it's a pleasure to invite Dr. Minakshi Sundaram sir, SMS sir, is one of the integral part of our program since the beginning and has been our course director ever since. Sir is a consultant neurologist at the Apollo Specialty Hospital, Madurai. Sir has more than 2 decades of experience and has been a gold medalist. And the Best Outgoing Student Award also was awarded to him in Bangalore. He's got various other awards of the best researcher for the 10th annual conference of IIN Lucknow, etc. Sir has almost 29-30 journal publications and various book chapters as well under his belt. So, sir, it's a pleasure to have you here today once again.
Thank you,
With
sir.
this, I will take the pleasure to also invite our esteemed moderators. So we have Dr. Balamurugan Narasimhan sir. Sir is a senior consultant neurologist at SIMS Chellam Hospital. Sir is contributed author and in various textbooks of emergency medicine, practical neurology, and neurological examination, and many more. Sir has more than 25 publications under his belt and has been a guest lecturer for more than 100 lectures in national and international conferences. Sir is a course director in the Fellowship in Neuro Emergencies by the Indian College of Emergency Medicine and has various honors and awards under his belt. So we welcome here today for this wonderful no thrombosis workshop. With this, we move on to our second moderator, Dr. K.K. Pritchett. Sir is again a senior consultant neurologist at Coimbatore with more than 2 decades of experience once again. And areas of interest are headache, demyelination, and stroke. And currently, he's, as I said, a senior consultant neurologist at Coimbatore. Sir is a well-renowned neuro, and we are very pleased to have him here today with us on this panel. So we welcome you here, sir, today. With this, I move on to our esteemed speakers. So we have Dr. Divya Selvaraj, again a consultant neurologist from Kaveri Hospital. Ma'am has various publications under her belt, like the role of near-infrared device as a screening tool for detecting intracranial hemorrhages in stroke and trauma, and also other scientific papers. Ma'am also has a lot of awards and recognitions under her belt, like the gold medal and various winners in state level neurology, postgraduate quizzes, etc. So it's a pleasure to have you here, ma'am. And we are looking forward to an insightful discussion based on the case study that you present. And finally, our second speaker, Dr. Swati. Ma'am is again a consultant neurologist at Kaveri Hospital, Chennai. She has multiple presentations in various national conferences, including INCon, Shine, Epicon, etc. She has presented various posters and as well publications which are under the national and international level with JAPI, JMSCR, International Journal of Medicine, etc. She has been certified in head and facial pain as well, and e-poster presentations in 2024 and 2025 Canada Alzheimer's Association International Conference as well. So, ma'am, it's a pleasure to have you here today. And with this, I hand it over to SMS sir for taking the delegations ahead. Over to you, sir. I'll stop sharing my screen.
Thank you, sir. At the outset, a warm welcome to everyone during this very important Navaratri festival. And we all know that the most effective maneuver for salvaging an ischemic brain tissue is timely restoration of cerebral blood flow. And that involves reperfusion therapy with the effective management strategies like tenecteplase. And month after month, we have been learning from esteemed speakers in this forum who share their knowledge, because you can always, get some knowledge about cases, and through that we can build our wisdom. So with this short introduction, I hand over the mic to my colleague, Dr. Prachet, who is a great teacher who continues to teach every day in our Nimans Forum. Prachet, over to you. Balmurugan, has he joined?
Yes, sir.
Okay, Balmurugan, welcome. So both of them, my colleagues. Both of them are wonderful teachers. And to just put in the perspective, Dr. Balmurugan was recently awarded yet another, best teacher award in our state. It was given in one of the national forums now. You can add it to your list. Balmurugan and Prachit, please take over, please.
Prachit?
Yeah. Carry on.
Yeah. Yes, good evening to you all, Navratri wishes. And I think we straight away go for the presentation. And the first presenter is Dr. Divya. She's from Salem. So some of the cases already I know. So we'll ask her to start the presentation. Over to Dr. Divya Selvaraj.
My privilege to be a part of a speaker in this national workshop under the guidance of Dr. SMS sir and my mentor Dr. Balmurugan sir. Unfortunately, my video is not opening. Anybody can share my slides?
Yes, madam, I'm sharing your PPT. Some of the videos I have downloaded, madam. Just now I have received from you. I'm just sharing the screen, madam. You give me 1 minute.
It's visible. Yeah. Thank you so much.
Madam, please let me know if you want me to change the slide. I can
Please
change.
go ahead. Yeah. Go next. Next. Yeah. Over to you, ma'am.
Dr. Divya, we are not audible, is it? Dr. Divya, can you unmute and then talk? I'm not able to hear anything.
We can't hear either, sir. I think ma'am is facing some technical challenge.
Can you call up, madam?
Yes, sir. Can you able to hear me?
Yeah.
Yes, ma'am.
The slides
Yes,
are
madam,
not
we can hear you. I hope you are able to see the presentation, madam.
No, I'm not able to see it.
If Divya ma'am is facing some challenge, will it be fine if we can move to the next speaker, Dr. Swati, and come back to Dr. Divya in a while?
Sure, sir. Yes.
Dr. Swati, would it be fine for you?
Yeah. Yes, sir. That would be
Great.
fine.
Krishna, please stop sharing. Yeah. Dr. Swati, you can share your screen.
Yeah. Just a second, sir. I think I've shared my slides with them if it is possible because I honestly don't know how to share the screen.
Okay.
I'm really sorry. Yeah.
Krishna, do you have ma'am's slides?
Sir, just a second.
Yeah.
Just
You
received,
just
sir.
go down and press share. It should be able to be. It should be very easy to do.
Really sorry, sir. Caption settings. Sir.
No, just go down. Move
Yes,
your
sir.
cursor down. You'll see an arrow share.
Yes, sir. Share. Yes, I saw.
Yeah.
Okay, share screen. Yes, sir.
You should be able to do that.
Yes, sir.
Madam, if you have any video in your presentation which has
Yeah.
audio, you have to share with both.
Okay.
There is an option for you to share with both.
Is my screen visible, sir?
No, screen is
Yes,
not
ma'am.
visible. You go and you have to share. Madam.
Yes, I went screen share.
when you open the share button, you're able to see your screen in front of you. You'll have many things in front of you. Your entire laptop will be visible in front of you. Yeah, correct.
Yes.
Yeah, now we can see the screen, ma'am. Could you open your presentation?
Yes.
Oh, it's a mobile phone you're using to share.
Sir, really sorry, sir. Yes.
Doesn't matter.
Ma'am, if you can make it landscape.
Yes,
Yeah.
yes.
Perfect. This is great.
Perfect.
Please go ahead. Thank you.
Sir, so good evening, everyone, and I think it's a privilege to be presenting a case in front of all of you, especially when I saw all your names like Meenakshi sir is there, and I was actually very anxious, and honestly, I'm still more anxious even now. So I just have one single case, which was little pretty complicated for us to manage at Kaveri Hospital, and it involved a lot of multidisciplinary teamwork as well. So this is going to be about a tandem carotid and MC occlusion, which is very uncommon but carries a very high risk of intra-procedure reocclusion. And this management requires combining IV thrombolysis, thrombectomy, and carotid devascularization while balancing the bleeding risk. So going to the case report, we had a 64-year male who was a hypertensive. He presented to our casualty at 2:34 p.m. His symptoms were he woke up at 7 a.m. and he did his routine activity and was doing completely good. At around 11:30 a.m., when he tried to get up from the chair, he observed weakness of the left upper limb and lower limb, which was followed by slurring of speech and deviation of angle of mouth to the right. There was no history of any numbness, headache, giddiness, double vision, or swallowing difficulty. No history of any fever or systemic symptoms. He was last seen normal at 11:30 a.m. and he presented to us at 2:34 p.m. in the casualty. So stroke code was activated. Following which, when we assessed the patient was conscious, oriented, dysarthria was present, pupils were 2 mm reacting to light, extraocular movements were normal, there was no gaze preference, no homonymous hemianopia, no nystagmus, there was a right UMN facial palsy, no bulbar palsy, left-sided hemiparesis was present with a power of 1 in the upper limb and a power of 2 in the left lower limb. His sensory was impaired to touch on the left side. The plantar was flexor on the right and extensor on the left. The NIHS at presentation was 9. His vitals were stable except his BP was 188 by 100. So as he presented to us within 3 hours of stroke onset with NIHs of 9, we went ahead doing a CT brain. So we can see in this image, there is no evidence of any hemorrhage. And if we can still more look, there is mild hypotensity in the right perisylvian region and also in the basal ganglia, the lentiform nucleus region in the first and the second image. And in the third image, we can also see that there is a right hyperdense MCA sign. So with all this presentation, with no evidence of bleed, we went ahead lysing this patient in the CT gantry.
This patient had right human facial palsy with the left hemiplegia. Am I right?
Yes, sir, left hemiparesis. Yes, sir.
Left
No, no,
hemiplegia with right
no, no.
human
Well,
facial
it
palsy.
was left hemiplegia, left facial palsy only. She just slurred, I thought, in that. That's all.
I'm really sorry, sir.
Okay, can you
It's a left
put the
facial
slides?
palsy.
Yeah,
It is
yeah.
right human facial palsy with
No.
left hemiparesis.
Yes, sir. Sir, yes.
It's a typographic error or the
Yes.
patient.
No.
Right.
He had a left UMN facial palsy
So,
with
okay,
left
okay,
hemiparesis.
okay. It's a typographic error. No problem.
Yes,
Okay,
sir.
sure.
Sorry, sir. Sorry,
No,
sir.
no issues, no issues. Okay.
Yes. So considering there was no bleed on the CT brain and a patient presented to us in window period with the left MCA hypertension sign, we went ahead thrombolizing the patient and we also alerted our team, neurointervention radiologist on the same. The patient was thrombolized with inactiplase injection, 0.25 mg per kg body weight, which came to around 17.5 milligrams at the CT gantry after optimal management of BP, as his BP was 188 by 100 at presentation. And then we went ahead doing a CT angio from the arch to the brain vessels. And I think this would be a little fast. And we observed the right carotid at the bifurcation. There was a 90% stenosis with an unstable plaque. It's particularly at this point. is on the right side, the carotid. Now there's going to be a bifurcation, and yes, there was a 90% stenosis at the bifurcation. So this was our report. So we just stopped with the. I would play the video again because we didn't look into the MCA part. So the right carotid at the bifurcation, it was a 90% stenosis occlusion, followed by the MCA. MCA was very faintly visualized. However, we can see that the distal segments, the M3 and M4, were still probably getting good collaterals, and hence there was good flow in the M3, M4 distal areas of the brain. So we had the report of there was a large vessel occlusion in the right MCA M1 segment, and also in the ICA terminus, the clot length being greater than 2 centimeters. It was a tandem occlusion with an aspects of more than 6, and the collaterals, as per the reporting TAN, was more than 50%. There was good collaterals present. So there was calcified plaques along the arch and the carotid bifurcations with floating thrombus in the right carotid bulb, more than 90% stenosis, suggestive of tandem involvement with ICAT changes as well. So considering the NIHs of 9 and with the patient presentation within less than 6 hours and a large vessel occlusion, tandem occlusions, we went ahead doing DSA with mechanical thrombectomy with our neurointervention radiologist, Dr. Satish G. Sir. And these images were, the MR images were being reported by our neuroradiologist, Dr. Sriram Vardarajan Sir. So in this image on the left, we can see the right carotid, after its origin, has almost 90% of occlusions, just thinned out, and then there is a flow again. And then we had to go with doing balloon angioplasty, dilatations of this area, so that we could proceed the catheter further. This is the AP view where we can see, so the lateral view where we can see after the ICA terminus, there is complete occlusion. We are not able to visualize the MCA segment. Following which the guide wire, the catheter was passed, and the wire is passed beyond the site of occlusion. On the right image, the wire is just passed beyond the site of occlusion. And after which there was thromboaspiration being done. And after thromboaspiration, we could see a TC grade 3 improvement of blood flow. So TC the 3 is like complete. Even the distal branches are getting the blood flow very well. So TC grade 3 is like almost equal to normal blood flow as per the angiogram. So we obtained a TC grade 3 of flow after thromboaspiration from the MCA M1 segment. Following this, we were just waiting because the plaque, there was an unstable plaque with 90% stenosis. We just waited and observed for almost 15 to 20 minutes. And we found that the right ICA, which was actually dilated, was again getting re-occluded. So the left image, the right image was the first image. And after waiting for another 15 minutes, after almost 20 to 30 minutes of waiting, we saw that the vessels were again getting re-occluded. So since this was a very bad 90% unstable plaque, and we had already tandem lesions, and we had already done MT, we had thromboaspirated from the M1 segment. We had a multidisciplinary meet with the neurologist, the neuroradiologist, the neurointervention radiologist, with the neurocritical care team. And we decided to start this patient on IV tirofiban in order to prevent reocclusion. So we went ahead doing IV tirofiban, bolus alone was given, and then we went ahead doing a stenting as well for the carotid segment. So we can see in this image on the left where the carotid stent is being deployed, and after deployment of the stent on the right, we can see that the vessel is completely opened up. So this was a DSA procedure. I mean, I've almost told everything. So the right common angio showed a critical stenosis of more than 90% with an ulcerative plaque in the right common carotid bifurcation with a large vessel occlusion. And the diagnostic catheter was passed, and then there was in position the distal right CCA, and manual thromboaspiration was tried in the proximal right ICA, which did not yield any thrombus or plaque. And the lesion right proximal ICA was then crossed up, and under fluoroscopic guidance, we kept dilating the right IC occlusions. So after sufficient opening of the stenotic segment in the ICA, we just went ahead, proceeded to the M1 segment, and we put in the aspiration catheter, and we thromboaspirated the M1 segment of the MCA. After which, after the post procedure, we saw there was a total recanalization of TC grade 3 of the right MCA branches and its branches with filling of its distal branches. And then we just waited for 30 minutes and we saw there was more thrombus formation with reocclusion of the significant ulcerative plaque in the right carotid bifurcation. So we had an MDT as we said, and we then went ahead giving an IV tirofiban loading dose of 10 ml was given over 15 minutes. And then we had to do a carotid stenting of the same segment. And after which we had a good dilatation. The check DSA was done and we found that TC grade 3 recanalization was seen in the right ICA and its branches. So the procedure was terminated at this point. There was no untoward contrast reactions to the contrast media. There was no hemodynamic disturbance during the procedure. This is the image of the clot that was aspirated. But we went there doing a post-procedure CT brain, which showed us hemorrhagic transformation with contrast pooling in the right frontoparietal gangliocapsular region with intraventricular hemorrhage. We'll play the video on the right image. It was extensive intraventricular hemorrhage even in the third and the fourth ventricles as well. So considering these images of such a massive hemorrhage, and the patient was already thrombolized, post thrombolysis patient was also given IV tirofiban, and post that we found that patient had this hemorrhagic transformation. So we again had an MDT whether to reverse the anti-thrombotic, the thrombolysis, the fibrinolytic agent. So after a multidisciplinary team, we went ahead doing a platelet and TEG mapping at this particular point, and we also sent for serum fibrinogen levels. And we then decided to go ahead with reversing the antifibrinolytic agent. We went ahead giving cryo for this patient. See the next image. So this was the TEG reporting that we had done. The image on the right where we can see the R, K, and angle. So the parameters which are seen in the platelet mapping, the parameters which are mentioned, which is the R in a minute, the K in a minute, the ANG is the angle, and MA is the maximum amplitude, and LY is 30%. That's the lysis. So based on this first part of the report, the upper part of the TEG reporting, so the R and K actually tells us how the clot is going to form. The time taken to initiate the clotting is what is suggested by R, and the K is going to be the speed with which the clot is being formed. So these two parameters generally tell us about the role of heparin and fibrinolytics here. So if it is more than the reference range, if the duration of R and K is prolonged, it means the effect of fibrinolytics is over. So that means it's going to be the effect of fibrinolytics is over. And in our patient, we found that actually it was in the normal range. And then we saw the maximum amplitude. The second part where we are going to look into the ADP patient value and AA patient value. So the MA is maximum activity of ADP is 44, which was normal. However, the MA activity of AA was 16.8. So we just compare this with the reference range. So this basically tells us the ADP activity and the AA activity, and we are going to look into the ADP inhibition activity and the AA inhibition activity. So this is the way the mechanism of clopidogrel and aspirin takes place. So ADP inhibition is by this mechanism is one where the clopidogrel works, and AA is arachidonic acid pathway mechanism where the aspirin works. So we found that the AA inhibition alone was 94%, which means any value above 70% means the aspirin is functioning very well. And ADP inhibition was 40%. This is a mild activity of clopidogrel. When both of them are positive, it indicates that tirofiban is actually working very well. In our case, it was a AA, the arachidonic acid inhibition that was actually too high of 94%. And then when we went ahead retrograde with the history, we found that the patient was also taking aspirin, though he was not having any major stroke or any cardiac event. However, he was taking aspirin of 75 mg. So probably that was the reason. However, though the fibrinolytic activity was not that great as per the R and K, which were in the normal reference range, we went ahead giving cryoprecipitate for this patient of 10 units of cryo was given, and the serum fibrinogen which we actually got very later after we gave the cryo, we got it almost 4 to 5 hours later. Its value was almost 250. So usually when we give fibrinolytic agents, the serum fibrinogen values will be less than 150. Which indicates that the bleeding risk is going to be very high. Here, serum fibrinogen also seemed to be above more than 150. So considering all this, we actually went ahead and lysing the patient, and after went ahead giving cryo for the patient, and we also took a neurosurgery opinion, and they suggested for a conservative management. We also evaluated this patient whether there was any features of raised ICP present by using doing transcranial Doppler, and the transcranial Doppler, the pulsatility index seemed to be always less than 1.2, which means that there was not any great resistance of flow, indicating that there was no raised ICP. So we had actually serial monitoring being done, and we also went at doing a serial CT brain also. The way we found that the subsequent there was no particular hematoma expansion was observed in the next CT brain that we repeated after 48 hours. So there was a reduction in the size of hematoma, which we saw in the first image. It was pretty high. And this was the patient. He was intubated, and on day 2, he was obeying all our commands. His power was 1 in the upper limb. Now we can see his power is almost 3 plus. And even the lower limb, he was able to bend his knee. His power was almost 2 to 3 in the left lower limb. There was no hematoma expansion on the repeat CT brain. This was done on the next day after 72 hours of the treatment. And we can see there's only mild hyperdensities. Much of it had resolved. So the management was to put together thrombolysis with IV tenecteplase at 2:58 p.m. Patient came to ER in 2:34 p.m. and thrombectomy was done with thromboaspiration. TC grade 3 was obtained after first pass itself. There was a complication of reocclusion of the right ulcerated carotid plaque, and we had to go for a rescue IA intraarterial tirofiban bolus shot. Because we observed there was too much of ICH with intraventricular hemorrhage as well. We didn't continue the maintenance therapy of tirofiban in our patient, and instead we did the TEG and the platelet mapping and went ahead of reversing the patient with cryo. And the carotid stenting was done with distal protective device, and the final ensure was TC grade 3 of flow. The complication was CT revealed hemorrhagic transformation with IVH. The patient was extubated on day 3 with improving neurological deficits, and the power was almost 4 on 5, both in the upper limb and the lower limb. So the things that I would want to highlight in this case was there was tandem occlusions, ulcerated carotid plaques, and these are prone for a high intraprocedural reocclusions. Carotid stenting after IV thrombolysis carries high hemorrhagic risk, requiring individualized decisions. Multidisciplinary team management is also required, like TEG and platelet mapping, which balances the stent patency and the bleeding risk. So the meta-analysis data suggests that adding tirofiban to mechanical thrombectomy definitely has better outcomes, which is the MRS 0 to 2 at the end of 3 months, higher recanalization rates, lower reocclusion rates, and no excess of spontaneous intracranial hemorrhage or mortality, especially in large arteriosclerosis and when stenting and angioplasty is performed. Similarly, the meta-analysis to 2025 also showed the same thing, that there was good outcomes by using IV tirofiban or intra-arterial tirofiban. But however, when the other cases which we saw in the rescue BT trials, we found that these were the patients in whom they used IV tirofiban, but they didn't undergo a prior IV thrombolysis. But in our patient, we had a IV thrombolysis followed by intra-arterial tirofiban. There are a lot of case studies and literature which also talk about early initiation of tirofiban in patients post IV thrombolysis. Even after thrombolysis, after 2 hours to 24 hours is the time period which they say early initiation of tirofiban can be considered, but it has to be individualized on case-to-case basis. Like the patient is like having a capsular warning syndrome, which we commonly know, where we can still consider giving IV tirofiban after IV thrombolysis. 2 to 24 hours is the time period when we can give after IV thrombolysis. However, we have to balance between the risk of bleeding when compared to the block. So this actually goes with the literatures, but there are no guidelines as such established for the same. So based on the asset IT trial, these are they are phase 3 trial. How the results are pending, where in which they see tirofiban soon after IVT. These also actually reinforces that very early initiation of antiplatelet can be done after IVT. So generally, even starting aspirin, when we start aspirin, we usually start 24 hours post IVT. But then there is also now recent literatures which have come which suggest early initiation of antiplatelets, even aspirin. So this is a particular trial, tirofiban soon after IVT, which result is actually pending. And next, regarding the tandem lesions and carotid stenting, however, when compared to the normal cases where we do an MT and there's a reocclusion and then we use a IA tirofiban, tandem occlusions have a totally different challenges. So most of the studies indicate that tirofiban reduces the instant thrombosis versus aspirin when emergent carotid stenting accompanies the mechanical thrombectomy without excess spontaneous ICH. And case series of intra-arterial bolus with IV infusions where we give tirofiban and then continue with the infusions as rescue for reocclusion during intracranial stenting. They also shows good angiographic success without higher hemorrhage. So patients with prior IV thrombolysis, we still do not have a guideline or a complete data available. So pooled analysis of IVT bridged mechanical thrombectomy cohort show no significant increase in spontaneous ICH and potential functional benefit. However, we can use low dose. So subsequent slides, we'll also be seeing about the doses of tirofiban that we are actually using the standard dose and the low dose that can be done. But these are all not guidelines that these appropriately are being used on case-to-case basis. So, but we also know that our own American Stroke Association guideline says that routine antiplatelets after thrombolysis has to be started after 24 hours of thrombolysis because of the risk of bleed associated with it. So that is the guideline of AHA-ASA, which says avoid antiplatelets within 24 hours after IVT because of the bleeding risk. But this is however individualized. And when it comes to tandem occlusions, it is totally a different scenario then. So the dosing pattern, which I said, so the standard dosing pattern that is adapted for strokers also, even in capture warning syndrome where we use, it's 0.4 micrograms per kg per minute for 30 minutes, followed by 0.1 microgram per kg per minute as an infusion for 12 to 24 hours. And low dose IV strategies can be tried when we, in such cases, in mechanical thrombectomy, when we have a high risk for bleeding, then 10 micrograms per kg IV bolus can be given, followed by 0.1 mics per kg per minute for 24 hours. And there is also an IA rescue during mechanical thrombectomy where they are just using intraarterial bolus of 0.25 mg or 1 mg. 0.25 mg is the lowest that has been given in the studies. Most of the trials that are there are mostly using altiplase. So we've searched for some literature. We saw that NEJM says 25% tinactiplase. Some of the patients were 25% used tinactiplase, 75% were used with altiplase. Improved 90-day excellent outcomes were seen with low spontaneous ICH. But most of the patients in this study particularly were not scheduled for EVT. So we still need to have a lot of data and literature on the same. So multiple studies also show tirofiban as an adjunct to MT shows a better recanalization. And most of this we have actually already discussed. The role where in mechanical thrombectomy, most of the patients where they use tirofiban were actually not thrombolized. So they excluded patients who were thrombolized in this particular situation. And then the hemorrhagic transformation, which happens post the thrombolysis and the mechanical thrombectomy and the IV tirofiban that we use. So this tinactiplase, we know its mechanism, where it causes depletion of fibrinogen and the clotting factors. And in mechanical thrombectomy, we're actually causing a repeated endothelial injury, leading to even reperfusion risk. And you can also have a bleeding risk per se by doing a mechanical thrombectomy. And tirofiban usage also increases parenchymal hematoma risk because it's a potent platelet aggregation blocker. It works by GP2B3A inhibitor. That's the last step of clotting that happens the platelet. So that's the last step which we call as the rescue treatment. So there is a fibrinolysis, there's an endothelial damage and an antiplatelet blockade, all three together posing a very high risk for a hemorrhagic transformation. So the learning points here are tandem occlusions with unstable carotid plaques are high risk for intraprocedural reocclusion. Intra-arterial tirofiban with emergent stenting can secure durable revascularization in selected patients. Hemorrhagic transformation post-IVT and MT requires rapid multidisciplinary decision making. PEG and platelet mapping are very much valuable in tailoring the antithrombotic therapy and reversal. Favorable outcomes can be seen with timely and coordinated intervention even in complicated strokes. So tandem occlusions are really difficult and very difficult to manage with the high rates of reocclusion, and using the tirofiban with also stenting should be very important. And we also have to use our antithrombotics very carefully, especially when we are doing thrombolysis and also using tirofiban in mechanical thrombectomy. But all this with a good multidisciplinary team management can lead us to favorable outcomes. These are my references, and I thank my entire team who has always been behind me and making me learn more and more every day. Thank you, sir.
Thank you, madam. That was a very comprehensive presentation. Thank you very much. And convey our regards to Dr. Satish too. No, it was a fantastic presentation. It highlighted the few difficult points which we have to face when you are treating patients with of this manner. The
Yes.
first issue was that you had a very tough case on your hand, which was a tandem stenosis. Absolutely. So very difficult case, and congratulations to your entire team, because the mortality can be as high as 50% in such cases. And the morbidity can be, only one third they do well. So 2/3 they go away from us. So it was a really tough, challenging case. It was quite rewarding experience for you in the bargain. Absolutely very, very happy to know this.
Yes,
The
sir.
second point you brought out is about tyrofibran. So tyrofibran, now it is gaining popularity, I should say. When a few years ago, it was not in the routine list. Now people are really pushing it hard. The first is for the end, that is the early neurological deterioration, which you pointed out, which
Yes,
could
sir.
be per se or following IV. So those are the two things. The third thing is that again, patients who have deteriorated following your mechanical procedure, there they
Yes, sir.
push tyrofibran. And we have to really give a caution that it is still a difficult drug to use because it can be associated with hemorrhage, and we should be really aware of the risks which we are posing. And as of now, it is still not standard of care, which I believe should be explained to the patients
Yes,
before
sir.
we touch. Because I am
Yes.
aware of a very ugly incident for one of my colleagues where tyrofibran was used and they wanted to sue and all those things. So we should be
Oh,
aware that,
yes.
yeah, I was aware of that. So we should explain to the patient, nothing wrong in any indulging, but let us
Yes,
make
sir.
an informed consent for the family. So the good point here is that you used tenecteplase in your patient. That was the first point. The patient did well. But then we had a LVO to really manage. So you took him for further treatment. And then you had some complications and you went ahead with the tyrofibran. And then you had further complications that there was hemorrhage. But
Hemorrhage.
everything actually ended sweetly because patients came out very well. So I'll
Yes, sir.
invite my moderators to pass comments. Dr. Balmurugan and Prachit, please take over.
It was a very good presentation, and as Dr. Sundar said, it all ended well. I just have one doubt.
Yes, sir.
See, can you just post the CT when the bleed was there? Can you just post that image alone?
You could tell us what when she's posting your question, Prachit, to just
No, the
shorten the
question.
time and give
Yeah,
more
yeah,
time for
okay.
other person.
Okay, agreed. So the point is, I just want to know how much is the bleed and how much is due to contrast extravasation.
Um,
See, if the main thing is due to contrast extravasation, there is some intraventricular bleed. How much is due to
So they say that the intraventricular hemorrhage, the intraventricular extension is not most likely related to the contrast extravasation, especially when it is entering into all the ventricles, even including the fourth ventricle, third and the fourth ventricle.
Mm-hmm.
And I think there are some more in the sequences in CT. I don't exactly remember. I've been told by Dr.
Dual
Sridhar.
energy. No, there is something called dual energy CT scan.
Oh,
If you
yes, sir.
have that, if you
Yes,
have
sir.
that, you can differentiate easily. So here you don't know, see it, and at the outside it appears as though there is a large bleed. But actually, probably maybe the whole thing was just only intraventricular bleed and some seepage there. So if you do a dual energy CT scan, you can have a good prognosis at the onset. You'll be more confident in managing. So
Okay, sir.
probably that was the case. I am not very sure. That is one thing, possibility which we should always consider in such a scenario.
Yes, sir.
Because
Yes, sir.
it was very scary to listen so many things given. What you've done is very bold and courageous. I should congratulate you, but it's not easy to what you've done to get all things rolling. It's very, very finally the end result is good. That's very good. That's what we want. So this is one thing
Yes,
which you can look into, which will help
yes, sir. Sure.
to
Yes, sir.
guide you in
Sure, sir. Yes, sir.
Can we look at the Hounsfield units and will it make any difference? If we just put the cursor there and look at the, will it make a difference to differentiate
I
between
don't think
this
so.
one
I don't
on the
think so.
monitor?
No, I don't
Yes,
think
Sundar,
so.
that was one of the way of differentiation between hemorrhage and then contrast. But practically, how much it is useful when you look at that literature, they tell that you can differentiate these two things by looking at the Hounsfield unit at the contrast, and then in the bleed, it's obviously the difference will be there. But practically, in a given case, how much it will be useful, I don't know. You're right, SMS, that can be used. Hello.
Right, yeah.
Hello.
Madam, this tyrofibrin which we are using,
Yes, sir.
and then there are the clarification I would like to seek from you is the fact that the patient had hemorrhage
Yes,
and
sir.
the fibrinogen levels were not depleted, they said.
Actually normal, sir. Yes, sir. They were actually good, which suggested that the fibrinolytic activity was probably over.
So we believe that the tenecteplase activity, the fibrinolytic activity is extended to 24 hours. That's the premise with which we work.
Mm,
So that's the
mm,
reason why we administer cryoprecipitate. We look at the fibrinogen levels for the next 24 hours. Every 6 hours, we keep checking. So it
Yes,
was a
sir.
little, I couldn't understand the reason why fibrinogen levels was, how many times it was checked,
No,
and was it
it was only
consistently
checked.
low?
No, so it was only checked once at around 9:15 or 9:30 in the night. That was one when the sample was actually being sent, fibrinogen. I think there was a delay in sending the fibrinogen levels. How the platelet mapping was done early. Like cryo was given after doing a platelet tag mapping. But however, as you were right, sir, we found that the R and the K values, which indicates the role of heparin and or the fibrinolytics, how they are working, we found that they were actually normal. It was only the antiplatelet activity which was very high because patient was previously taking antiplatelets. So usually in this case, even platelet transfusion would have helped. But when we search for literature, actually in case of hemorrhagic transformation, there's more literature saying you go for cryo and plus or minus platelet transfusion can be considered. So this particular scenario was there where the MDT had a little discrepancies, like they were more in favor of the critical care side, that this is more of bleed because of fibrin, like the anti-tenecteplase. So this was one area where we little had issues, but we then, as a multidisciplinary team, we went ahead doing it. Similarly, the neurosurgeons were also of the opinion that because the extension of bleed was there in the ventricles, in the third and the fourth ventricles, they were more in favor of a bleed rather than an extravasation. I think even our radiologist, Dr. Sriram Vardarajan sir, was also pretty much in favor of bleed more than an
There was a
extravasation.
I think
However,
he was saying
I would,
additional.
I think
So
there are
bleed
both.
was when it was unequivocal evidence of bleed there.
Bleed
Prachet
is
sir
there.
was
yeah,
only saying about the extra component
yeah,
of
yeah.
the contrast. Madam,
Yes,
the
yes.
point is, yeah.
Yeah, sorry, sir. Sorry, sir. Please.
No, please go ahead, madam. Kindly go ahead, please.
No, sir. Sorry, sir. Sorry,
No,
sir.
madam, please go ahead, madam. Absolutely, you can finish it.
No,
No problem. You're teaching us a lot.
I would definitely discuss with my team as well again on that point of kite. And sir said this dual energy, that even I would discuss. I would probably discuss this with the team as well, sir.
Regarding the administration of cryoprecipitates for the postgraduates we are attending here. So our protocol is to check for fibrinogen levels at least 4 times, that is every 6 hours for the next 24 hours, which is the duration expected for the drug to extend its fibrinolytic activity. And our idea to keep the fibrinogen above, and the dosage we use is that 1 unit of cryo or an FFP would increase by around 5 to 10 milligrams per cent. So the premise we work with is that if a person has got, say, fibrinogen level of 100, that means we need to give at least 5 to 10 cryos and then repeat again at the end of 6 hours and do the same thing for 24 hours. By this, we would be able to ensure that the clot doesn't become big enough and scary for us. That is what we need to do in our cases. But madam has been quite confident in doing it, and very good success is the, what shall I say, the fruit of success is what speaks for itself, really. It's a phenomenal case. And the second thing is about the carotid stenosis. Really, it's a tough fast for us. We have really no clear answers there whether we should acutely in the intracranial we are going to do it absolutely. There is no controversy in that. But what we are going to do acutely in a patient who has got a proximal lesion is really still not clear. So whether we should stent it, whether we should do a balloon angioplasty and come, or we should leave it and see later and look for deterioration, whether we should do TCD monitoring up there. So many things actually crop up there. But bravely you have gone ahead, put a stent, and really patient has done well. So give us a follow-up also on this patient, madam. If Balu has other questions, I will wait, or we have to go to the next case. 9:16 is the time.
Yes, sir. Thank you, sir. Thank you so much, sir.
Very nice case, madam. Congrats once again. Balu.
Yes, sir. It's completely teamwork, sir. I would not take the credit for
Lovely.
myself. It's completely teamwork. With, of course, my senior urologist, sir. He was my backbone, Dr. Subramanian, sir. He's been always been my backbone, sir. Yes, sir.
Happy to know that, madam. One of success. Balu.
Thank
Yes, we should thank the
Thank you,
patient
sir.
also because agreeing for all these procedures
Yes.
within 24 hours, really, we should thank the patient and the attenders. And the one thing that, what is your say about tirofiban in this case, Dr. Sundar? Straight question to you.
See, tirofiban, frankly, I have no practical experience, absolutely. So tirofiban has been advocated in stroke in 3 methods. The first is preventing early neurological deterioration in non-cardioembolic acute ischemic strokes. The
Yes.
second one is as an adjunct to intravenous thrombolysis after you have administered antiplatelet antiplatelets routinely. And the third thing is to use as a rescue or an intra-procedural use during endovascular thrombectomy. For example, for reocclusion, for instant thrombosis, for severe residual stenosis, and maybe where we, for in this case, for example, a stent was placed, they would like to give antiplatelets, but our recommendation would prevent them from using antiplatelets. The reason is because the patient has been thrombolized. So as a short-term bridging, IV tirofiban can be used. These are the 4 areas where tirofiban can be used. There were 2 important trials. One was the trend trial, which was in JAMA. The second, I think, was asset to data. Both of them were favorable. But, one pinch of salt we should think of is both of them were Chinese trials, if I'm aware. So we have to wait for more trials, and then we may have a final answer. As of now, it is not a grade A recommendation. Individualization is more appropriate than recommending it as one shot. This would be my take on tirofiban.
Thank you. So do you use it in capsular warning syndromes?
I have never used tirofiban even once in my life. My knowledge doesn't permit me
The
to.
second question is that this patient, because this patient they had difficulty after that also the patient had that. What's your say of this underwent a mechanical thrombectomy, MC occlusion was there. What is your say of doing tackling the carotid problem immediately? So the problem is mainly the M1 occlusion.
Yeah, we have done both. Actually, M1 we will take it out immediately, but for the carotid we have divided view. So we have in our own team we have divided view whether we should aggressively do it or not aggressively do it. And the age also plays a very important factor, I feel, not just for the patient, for the doctor also. I remember a few years ago, I'd be very aggressive, I say, do it. Now I really sit and think back what I'm going to really give to the patient. I didn't have this much success in our patients, I should be honest. So a little I take a back seat here in doing it with it. I leave the family's decision as final. Nevertheless, my way of putting across may be different here, because some gray hair has joined my head, which clouds my opinion, I must say.
One more question to the presenter is that the floating thrombus is generally used for the Doppler studies. The CT angio, can we use that word, that floating thrombus? That's one question that was it a Doppler finding or CT angio finding? You said the CT angio. But
It is a CT angio, sir. So we have a radio. So sorry, sir. Yes.
No, just to clarify, a floating thrombus means very simple. When a thrombus is covered on all 3 sides by blood, that is floating thrombus. So it is attached in the stalk only on one side. That is the meaning of floating thrombus. So it can be, technically speaking, it can be in CT angio also. Yeah, so the issue is how to tackle the floating and this floating thrombus. There are three approaches. Some people say, I mean, they're not related to this case. I'm just talking about floating thrombus. Some people say go ahead and excise. Some people say give only anticoagulants. Some people say even antiplatelets are good enough. All three approaches are okay. But generally, the favor is towards if you find only a floating thrombus, there are many times you'll find a floating thrombus, but patient will be walking around. There you give anticoagulation for 6 weeks and then repeat a CT angio. That is the meaning of floating thrombus. Here, I don't know what it means. I probably presume that there was an ulcerated plaque, or on top of that, there was a thrombus which was sitting. Probably that's what is the meaning.
Balu, I think we should stop the
Yes,
discussion
yes,
on
wonderful presentation, Dr. Swati. We congratulate you.
Thank you.
Fantastic
Congratulations,
presentation.
Madam
Thank you.
Lady.
Thank you, sir.
One
Thank you, sir. Meet.
Balu, can I the second speaker? You can. Balu? Yeah.
Divya ma'am. Dr. Divya.
Yes, I mean,
Yes,
I'm just trying to share my
we can see the screen.
visible, sir.
Yes, ma'am.
Without much delay, I will start with the presentation. Practical difficulties and large vessel occlusion from drip to shift. Series of 3-4 cases with some commonality. First case is a 24 years old gentleman who reached emergency department within 45 minutes of sudden onset weakness of his right upper and lower limb and deviation of mouth to left. His onset time is 2:45 p.m. and he arrived to our ER at 3:30 p.m. We were surprised and worried why a 24-year-old man developed a stroke. Then on reviewing the history, they told that he was diagnosed as a left testicular germ cell tumor 2 months ago. For which orchidectomy was done, and he has undergone chemotherapy also. So he has completed a 4th cycle of chemo. While returning back from the chemotherapy, the patient developed weakness. Quick ER assessment, his vitals and GCs were all stable, and he had right human facial weakness and hemiplegia, NIHSS of 7, normal blood sugar. This is the patient. He has right facial weakness and right upper limb 0/5 and lower limb minimum 1. So we proceeded with MRI without any undue delay, and the MRI doesn't show any diffusion restriction, but the MRA showed left MCA stem occlusion. So the radiologist immediately called me up and said there is no infarct, only there is a left MC occlusion. Whether it could be acute or chronic on the background of CA as per the history he told. And the ER physician also had a doubt that they raised the question can be thrombolized in cancer patients. So we had a dilemma whether to thrombolyze or not. Then as per literature, there is no such contraindication in a cancer patient with, to treat with RTPA, although intracranial neoplasm and some bleeding diathesis are considered contraindications. So we counsel the attenders for thrombolysis and need for mechanical thrombectomy if there is no improvement, since there is a large vessel occlusion. In the meantime, the radiologist, the patient was still in the MRI gantry, so the radiologist repeated the diffusion sequence alone. Now he got the hyperacute infarct in the left capsule and corona radiata. So meantime, we have sent these investigations, which we are not doing routinely for all patients before thrombolysis. But for this patient, since he had a malignancy and received chemotherapy, we did these investigations and proceeded with the tenecteplase injection at around 4:15 p.m. So after thrombolysis, there was no clinical improvement immediately. So the attenders were much worried. This is the only son who had recently cancer diagnosis following which surgery, chemotherapy, then now stroke. So they were literally worried and they were thinking so much for thrombectomy. Then finally they gave the consent and our IR team was ready. But before shifting the patient to cath lab, I just wanted to know whether the Tenacti place has really opened up MCA. So on the way to cath lab, I just repeated the MRA alone, which just took 3 minutes. In this MRA also, there is no opening up of left MCA, but we could see some collaterals, which was not there earlier, pre-thrombolysis. So in this meantime, I had a really tough time with radiologist stating we are wasting the time shifting to the thrombectomy. After the patient showed improvement in facial weakness, his hemiparesis, everything improved even before shifting to the cath lab. From MRA. So now, again, parents were confused what to do now, whether to go for thrombectomy as planned earlier. So we decided to just take him up for DSA and see whether the really vessel has opened up or not and to proceed with the thrombectomy or not. So in DSA also, the vessel has not opened up, but the collaterals are very good. So again, with the team of radiologists, intervention radiologist and myself, we discussed with the attenders whether to go ahead with removing the clot and opening up left MCA. But there is a chances of some hemorrhagic transformation or hemiplegia developing again. So the decision made by the attenders and ourselves was to observe closely for the next 24 hours. If there is any worsening of the weakness, we'll proceed with emergency mechanical thrombectomy. So he was observed in ICU till next day, and there was no clinical deterioration in his power. So next day he was shifted to ward, and then we evaluated for his stroke workup, whether it is due to the malignancy or something else. Routine carotid and vertebral Dopplers were normal, echo normal, tumor markers were negative, even PET-CT was normal, thrombophilic panel normal. Only thing the history was he was treated with injection bleomycin 4 cycles. And he completed the chemotherapy also. On reviewing the literature, the stroke after chemotherapy for testicular cancer has very well been documented, but the cisplatin is most commonly associated. Even bleomycin can produce stroke as per the literature. So everything went well. One find on third or fourth day, maybe the patient complained of pain in the right leg. Clinically, all peripheral vessels pulses are palpable. There is no hematoma on the catheter insertion site. Venous Doppler were normal. Arterial Doppler in the right lower limb showed a thrombus in the right dorsalis pedis at the level of first intertarsal space, a very distal thrombus. Then concordance with the oncologist and vascular surgeon, we started him on low molecular weight heparin. So on follow-up, the patient is doing well. For the past 6 months, he is on follow-up, no further weakness, no other neurological complaints. So the lessons learned from this patient is that there is no strict contraindications as quoted earlier. And other things to be discussed is that large vessel occlusion, whether we have to wait till improvement or we have to shift immediately for mechanical thrombectomy. These questions were in my mind, and I will present the other 3 cases also. Finally, I will summarize and over it to the experts. Second case, a 68-year-old male. He was admitted under a urologist with a history of urinary retention for 10 days. But he had a significant past history that he was previously admitted for CCF pneumonia. He suddenly developed a sudden onset weakness of the left upper and lower limb. For the past 10 minutes, fourth stroke was activated. His NIHSS was 15. So patient There also gaze preference to the right and left hemiplegia. So we did ECG also to be on the safer side before thrombolysis, and we shifted him for MRI. This patient had a diffusion restriction in the right MCA territory, and the right MCA M1 stem occlusion was there. So we did thrombolysis and explained to the attenders that this is a large vessel occlusion, so he may need mechanical thrombectomy. But due to his severe comorbidities like severe LV dysfunction, dilated cardiomyopathy, creat of 2.8, hyperkalemia, the attenders were reluctant for mechanical thrombectomy. Again, this patient, the left MC has beautifully opened up with all the collaterals flow, except for a significant Peter segment ICA stenosis, critical stenosis was there. The patient also clinically improved well his sensorium. Very good.
கை தூக்குங்க பார்க்கலாம். இன்னும் நல்லா தூக்குங்க. கை பிடிங்க.
So this is on the same day. The next day after 24 hours, he even recovered well with very low cases. So coming to case 3, he's a 47-year-old gentleman with history of sudden onset giddiness and unsteadiness of gait and speech disturbances since 3 a.m. So patient arrived to ER at 5 a.m. in the morning. His GCS is good, NIHS was 5 and vitals were stable. This is the patient on arrival. He was a little bit drowsy, speech disturbances and ataxia. His power is okay, but he had a severe ataxia. On further probing the history, he had a history of rheumatic heart disease with severe MS and recently started on tablet acetone. So we took the blood samples for PTINR and sent the patient to MRI. So he had acute left cerebellar infarct, superior cerebellum, and he had some reduced flow in the basilar, a short segment occlusion in the basilar artery. So by the time the INR also came, and finally we thrombolyzed the patient at 6 a.m. After thrombolysis, we repeated the MRA. Again, the basilar artery has opened up well. And the patient also showed good improvement in his ataxia, speech, everything. So coming to the final case, he's a 33-year-old gentleman with complaint of weakness of right upper and lower limb with aphasia for 3 hours. Past history, there is a cardiac surgery done 15 years ago, and he's on some medications, but the details were not brought with the attenders, and NIHSS was 10. So at this age, cardiac surgery 15 years back could be rheumatic heart disease, we thought. So we sent the blood samples for PTNR and shifted the patient for MRI. Clinical findings, he was a bit confused. Partial comprehension was there. Motor aphasia, right upper limb power 0/5. So his MRI showed a large core infarct in the left MCA territory. So already it's been past 3 hours. Patient is on acetone, might be on acetone as well. So the core is also large. Whether to proceed with thrombolysis or not, we are literally worried. But there is a mismatch between the diffusion and flare. So we went ahead with the ASL also. So there is a clear reduced perfusion over the left MCA territory. By then, INR report also came to be 1.2. So then we proceeded with thrombolysis within 40 minutes of his arrival. So this is pre-thrombolysis MRA when compared to the post-thrombolysis MRA. Though the MCA is not fully opened up, there is a partial recanalization. So the right upper limb power has dramatically improved that he could write on his own without any difficulties, but the language problem still persisted. He was able to read letter by letter, but he was not able to comprehend what he has written. He is just able to copy whatever has been given. On follow-up, even this language dysfunction is improving well. So on summarizing, the first case came with NHSS of 7. So all cases are thrombolyzed with injection tenectis. The large vessel is not opened up in the first case, but collaterals have developed. Second case, MCA itself opened up. Third case, basilar artery short segment occlusion was opened up. And the fourth case, MCA was partially opened up and the patient also has partial improvement. All these cases, first case only we denied thrombectomy, and second case due to comorbidities, there is a high risk to explain. All other cases, they were not willing for thrombectomy. So the practical difficulties, what I faced was after thrombolysis in large vessel occlusion, if the patient improved, so after the patient's clinical improvement, whether we go for angio, if at all CT cerebral angio or MRA or straight DSA. If patient is not improved, definitely we will go for mechanical thrombectomy. If the patient has improved and the vessel opened up or any partial improvement with the collaterals, what we have to do. The patient if improved and the vessel not opened up, what we are going to do. These are my queries. So over to.
Thank you, Dr. Divya. First is congratulations, because you said, in your entire presentation, you could see the touch of Dr. Balmurugan, your mentor. Nicely made videos before and after, properly documenting, not like any one of us. Proper documentation and then compiling and presenting. Really fantastic, madam. And you did not miss even one medal through your entire career. I saw that.
Thank you, sir.
Congratulations, really. So coming to these cases, madam, the first thing is that I would like to make a request, or rather it is our own experience which I am sharing in our hospital. See, for instance, the doubt starts coming up whether you will do thrombolysis, yes, no, large core, small core. All these things creep up because we are looking at MRI. In our hospital as a policy, what I have maintained is that if a patient comes less than 4.5 hours, they cannot be shifted for MRI. It will be only be CT. Then there will be no doubt in our mind. In all the cases, if you did a CT, you would have no doubt at all. We will not be thinking of the core or anything. And there is a distinct advantage which we gain by this. Number one is obvious time. Though radiologist tells you that we would do everything within 4 minutes, 5 minutes, 6 minutes, hour, we have our own stroke protocol. All you require to do is diffusion ADC, flat, and one angio, if at all. This is the radiologist protocol. They are only talking about the scan time. They are not talking about the shifting in time, shifting out time, the attender wastage time, wherein one attender always runs with the, a cell phone inside and then you have to pull him out, and all those circus which happens really. So this is a practical issue we have faced, and as a protocol less than 4.5 hours is just CT. We'll have no doubt at all in our mind. And we can always thrombolyze the patient inside, or one of our colleagues, our emergency doctor, Dr. Madan is one person who favors only emergency thrombolysis. But then we had some other difficulties where, we went ahead to the emergency room back. Otherwise, we were doing for a short time CT scan thrombolysis. But if a patient deteriorates, they blame you. That's why we shifted back to emergency and started doing it. But these are practical things which we have seen. And then the advantage is that we can always, after the CT thrombolysis is done, you can shift back and now you can do an MRI. Then you can see whether the vessel has opened or not. And then we can make our decisions. regarding when to do, how much time to wait, I request my esteemed moderators to give you on that. Prachet and Balmurugan will teach us about it. Really fantastic cases. The compilation is just too good, I thought.
Thank you, sir.
Rochit, you will say,
Yes, sir,
yes,
good
some practical
cases.
difficulties we
This,
come across. Yes,
yeah,
Prashit.
this is the typical practical scenarios we come across. So, see, the ideal recommendation is you do CT angio, thrombolyze, thrombectomy. That is the thing. You don't wait whether patient improves, not improves. You don't wait. That is not the recommendation. So you do a CT angio and then thrombolyze. Okay, if there is CT angio, if there is no large vessel occlusion, don't thrombolyze. You do CT, you thrombolyze. Sorry, if there is no large vessel occlusion, no thrombectomy. Otherwise, you just do thrombolysis. So it's either thrombolysis or thrombolysis followed by thrombectomy. Now, the question is, you wait. How long do you wait? That is the problem. Okay, if you say half-life of tenecteplase, it is, I think, 11 minutes or so. So how long do you wait? So if you say one half-life, you will wait for 15 minutes, and another 15 minutes. You can say fibrinolytic action lasts for some time. See, this is always a problem. I understand your practical deficiency. I also face the same thing. The problem is to say that you spend so much, we'll do this. Sometimes in hindsight, we would say that patient maybe he would have improved, so whether to do or not to do. This is always a big problem. So ideally, you do a CT, you do a CT angio, and then be very clear. Another problem with the MR based this one is slow flow is equal to no flow. Okay, so all these cases, there could have been some slow flow which should have opened up, and then that is why this has come. You can technically argue that there is no total obstruction, there is only slow flow. So always the decision for thrombectomy should ideally be made with the CT angio and not with an MR. If you want, you can do a contrast MRI, but again, that is even more time consuming, as Dr. Sundar said. The third is within 4.5 hours, as Dr. Sundar said, MRI will add confusion only. So you just do CT and then you go ahead and thrombolyze. The indication for MRI within 4.5 hours will be when, for example, the deficits are very minimal, NIHSS is 1, 2, or you are not sure of the stroke. Sometimes it can happen non-dominant side, or the patient sometimes this aphasia, malingering can come. Though technically you say that the patient is asked to write, patient will be able to write in if there is malingering, or patient is not able to write, that means it is a real aphasia. So these are some scenarios where you need MRI, otherwise CT is good enough. So the take home point is what I would say is see the problem is you will decide not to thrombolyze and then patient worsens, then what do you do? That is a big problem. So always better to go ahead and do thrombectomy. Okay, don't wait. If money is the problem, then you can say, okay, yes, you do this, you wait for some time, wait for some time. So you do one bypass of all these things is you do a thrombolysis, wait for 15 minutes or 30 minutes or so, one half-life at least to complete, do a CT angio. If CT angio, the vessel is still open, then nothing. The CT angio, the vessel is blocked, advise thrombectomy. Then the patient doesn't give consent, that's a different scenario. See, problem is if the vessel is still blocked and the patient is improved, it is still better to do a thrombectomy to prevent further worsening. Okay, that is the same. But this is a very tough scenario. It's easy to talk, but practically when it comes in the ER, it is very, very tough, not easy at all.
Wait for the improvement to occur, but the time the patient takes to decide on thrombectomy and shifting to cath lab, in the meantime, I observed the improvement in these patients. Other two patients, they
if,
denied the thrombectomy. So we could
if there is
document.
a LVO, if there is an LVO, as Prachet said today, recommendation is that even if the patient has improved, you need to offer them mechanical thrombectomy. That is a guideline today. Whether the patient will accept or not, we do not know. Maybe a financial issue, or the patient would like to wait. The ball is in their court. From our side, if there is an LVO, we straight away offer. We don't hesitate at all. The family design. And regarding the waiting part, our protocol in our hospital is that we don't wait at all. There's no waitage, no waiting period. The half-life of tenecteplase is 20 minutes, which is roughly the time you'll be taking to finish and go and talk to them. And then you can make a decision. Altiplase is only 5 minutes, that's why it's infused. Here it is around 20 minutes. The effect lasts for up to 90 to 120 minutes. The initial distribution is 20 to 25 minutes. So with that, we may be able to decide that. So we really offer to the family and let them take a decision. Only if the vessel is completely opened up, that's what we do it in a different manner, as I told you. This we learned with the experience. You do a CT, then you have time to go back. The shifting time will be roughly 10-15 minutes. Then we will know whether that vessel is opened or not. By which way we are circumvented. Earlier we were doing this, what Prachet was telling, we were doing it. Not necessarily CT, we thought we'll do an MRI, and we had experimented all these things. MRI brain with MRI angio straight there. Then CT brain with CT angio. Do CT and then repeat. All these circles we have done. Nowadays it is easy for us. 4.5 hours or less. We always do CT, then take the patient for MRI. There we can, and we at this point of time, we don't do a stroke protocol MRI. We do a complete MRI. What difference does it make? Because at that time, we are given the IV, the patient's relatives are sitting and talking about, consenting for whatever we are offered. We have all the time in the world to, in a luxurious manner, look at the complete MRI and come to a decision at that time. At the time, we don't hesitate at all. Whatever studies we want to do, ASL, whatever is in the world, we try to do it. At the time, we have no hesitation. This is our protocol. It has been fortunately successful for us. But that is a really nice presentation. Regarding the INR part which we are talking, madam, we do it in our hospital with the point of care machine. So like you have a blood sugar, it's good idea to keep it in your emergency. Because when you have these RSD cases, it goes and comes back. The turnover time is not less than 30 minutes. The best of the hospitals is 30 minutes for you to get a coagulation perfect. In the first case, you have no other way, because if the patient has received chemotherapy, then there is a high chance that though the patient has clotted, that's what we are actually treating for, still we need to rule out a thrombocytopenia in that case, because antiplatelet and the thrombocytopenia related to chemotherapy is a real danger for us. The patient may bleed, and one of the guidelines is to ensure platelet count more than 1 lakh, which we never see in our MNC. We just go ahead and do it. But in that case, I think that it requires caution for us to wait till we get our platelet count in our hand. So in that patient, we can do comfortably an MRI also and do it, because we will be anyway wait for the platelet count. In all other cases, for us, it is point of care INR, we go ahead and do it. Balmurugan, your call.
Yes. How many minutes in your center you take for MRI? Dr. Divya, how many minutes it takes? Because for your MRI to complete, and then because some of the centers, even in Western world, they follow MRI rather than the CT. I agree with you. It depends upon your comfort, your center, what protocol you follow. In your center, the MRI load is less for other cases, and then you can easily move the patients. And what's the average time you finish your MRI? That matters a lot. Dr. Divya.
Yes, sir. We do diffusion, flare, and then MRA. Then we, even before MRA, with the diffusion, ABC, flare, I thrombolize, MRA will be done. These
So
are
how
my
many minutes
initial
it takes
cases
average time for your
average
your
10
ER
to 12 minutes.
to making a decision? Average time from your ER and making a decision.
Door to needle thrombolizing time, sir.
No. Door to needle is different. You decided to do thrombolysis.
Yes, sir.
Hello.
Yes, sir.
You decided to do an MRI. From that point onwards, and getting the MRI film or seeing the MRI film, and you are making the decision of thrombolysis. So generally for CT, it takes 10 minutes, that's all. So you shift to CT room, and then you see that, and then in the CT room itself, we can make a decision and shift from the CT to the ER. It takes another 1 or 2 minutes. By the time the attenders will be ready for this thrombolysis. But most of the time, we will be educating them about the thrombolysis even while the CT was going on. So this time takes around 10 minutes to 15 minutes. So what's the time taken in your center from, I'm not asking about door to needle time.
Yes, sir. Got it, sir.
If others take 10 to 15 minutes, if your MR also takes same 10 to 15 minutes, it is your discretion always. Most of the MR center, they take nearly about 25 to 35 minutes. What is your average time?
My average time is 15 to 20 minutes, sir. Even
Okay.
before the MRI film gets completed, we prime the patients for
I
thrombolysis.
agree fully with this. The time that I'm asking is that what is the time taken from you shifting from ER and then deciding for about thrombolysis?
The minimum time I done was 15 minutes, sir.
Okay. So minimum is okay. What is the average you can calculate and then you can throw more light. So because the average time if you are maintaining from this particular point is that a lot of other factors are there. Leave about that. The average time you are shifting, you decide I want the MRI. That time to going to the MRI and even in the GANT itself you are making decision, yes, I am going for thrombolysis by seeing the film. So the time that you could maintain around 15 minutes, I would say that's a reasonable one. SMS, your say on it?
Yeah, well, as I told, well, I mentioned our protocol. So
Yeah.
if you look at the protocols all over the world, MRI versus CT, this debate always goes on. Even in our stroke conference, there is a debate session for this. But as I said, I go for CT. The reason is
Yeah.
because less confusion for me.
Yeah.
Because I would not have to have another discussion. And I am within the right limits of the law. Confusion less. Straight away, I see CT is nothing traumatized. That is all for me. After that, I can worry about large core, small core, all those things. I can sit and think about it. And in our hospital, fortunately, I should be proud to say this, long back we got away with this. That is, the patient will be charged only for the MRI. We would be doing a CT thrombolysis and do an MRI. The charge is only for the MRI. So by which we have been able to reduce the cost. I am sure even in other centers they are following the same protocol. So with our cost has not escalated, we get what we want. This is how we act. It is always CT based, quick, finish, over.
So I understand that there are two issues that SMS is addressing, not only the time and the confusion about your learning curve, about your the standard way of differentiating your perfusion or your matches, mismatch and core, large core, small core. Fine. So if you are coming up with the lesser time of your thrombolysis period in time taken in the MRI, and your center is good at doing an MRI very fast. Okay, go ahead, but you have to be very clear in not getting confused with this large core and then this mismatch problems. That's the only thing that. And
Supposing, Balu, I address your question right now, but I have a question to ask you. Supposing you see a patient who comes within the window, say 3 hours, he's a fast progressor, and you do a MRI and shows a large core, what is your decision there?
yes, the prognostications will be different. Yeah, I know the prognostication will be different. So when you see a lacunar infarct, a dense hemiplegia in MRI, we may be seeing a lacunar infarct, we may be seeing a developing a large infarct. Both are possible. Okay, though clinically we could say that what do you call Gauss pulses, all those things are there. But even then, both possible. In the situations, if the MRI, somebody could see a large core, the pendulum will go towards the thrombolysis complications and then not improving. So that margin probably she may be getting in her learning curve. So
Agreed.
So that's the one thing that. So, but again, the time. In her center, if she is able to do within 15 minutes, I would say that fine. That's not. If she takes 30 minutes, then that 15 minutes extra is really not good for any cases of thrombolysis because most of our patients come between 2 to 3 hours only. Not very rarely they come within 30 minutes. Again, Dr. Divya is trying to tell that she is not trying to emphasize that we should delay the mechanical thrombectomy. I think that am I right, Dr. Divya? So some of the cases which she got that where thrombolysis could not be done because of some delay, the attendants are not willing. Those are the patients she collected and then she's trying to put. There are some group of patients, they are improving with a large vessel. It could be, as Prachit rightly said, that it could be a low flow or whatever it may be. What are they? Whether we could identify earlier and collecting those cases alone, whether that will throw more light in future. So that's the way that I look.
For you. One more question for what was the time duration between testicular surgery and the stroke, madam?
Sir, 1 year, sir.
1 year. It's a long time for us. Because even if it were close, we wouldn't have bothered really. unless we have opened the abdomen and there is abdominal bed related risk of hemorrhage. How long we would allow if it was a shorter time? Beyond how much time we can do it, you think, Balu?
Which one?
No, we say that no recent surgery is a contraindication. This is an abdominal surgery or a
Yeah,
testicular surgery. So how much time should be given for a testicular surgery? 1 year is good enough. But within what time we would not have done in this case?
I don't have answer. I don't have answer.
3 months, is it reasonable?
3 months.
3 months.
No. If you
3 months
see
for a
the
major surgery.
This testicular surgery is abdominal surgery, is it?
no, if
It
you
is
see
like an
the
abdominal surgery. Huh?
no, if you see the latest update, I think they removed the word contraindication. They put
Yeah.
warning.
Correct. Warning.
Relative.
They have put warning, which means they're indirectly trying to say that it's not an absolute contraindication. That's what is the meaning trying to convey. So I think what everything is changing. So
Yeah, there will be only one absolute contraindication. There is a massive bleed.
yeah.
I use the word massive bleed.
Mm. See, and one more thing is if you are using MRI for acute stroke, go ahead, no problem. But you should be very clear. You should not get confused within 4.5 hours that there is diffusion flare, there is no mismatch, so I will not
Mismatch,
thrombolize.
nothing. Yeah.
Yeah.
So nothing like that.
That you
4.5 hours, you have to be
we
very
can take
clear.
for another issue is that when you get the MRI and then the report there is some small micro bleed. So they'll tell it to the doctor, oh, there's a bleed the doctor has given from. That's the one thing that we are very clear in educating your colleagues. So practical difficulty with the MRI. There will be a lot of microbleeds in most of the amyloid, even non-amyloid. So that causes confusion. That should not be a confusion for your referral doctors or your colleagues saying that this patient has been thrombolized with a bleed small here and there. So good job, doctor. You can collect those cases,
Madam,
you can throw some more light.
Madam, it was a fantastic presentation. 4 cases and the summary slide was just awesome, madam. Keep it up, really. Balu, congratulations to you also. Congratulations.
This is her job. I'm not attached to that
Fantastic.
hospital. She's doing
Really
very good.
fantastic, really. So I think we have come to the fag end of our presentation. It is 9:57,
Seven.
almost, yeah. I think, we should, call it a day, I believe, because otherwise we'll be extending too much into our time. Dr. Ronak, I hand over the mic to you. Please take forward. Thank you very much for the opportunity.
Thank you,
so
Sundar.
much. Yeah, it was a wonderful discussion. I think the entire audience must be very enlightened with all these clinical pearls that all of you have shared. Thank you so much, Dr. Prachit, Dr. SMS sir as well, Dr. Bala Murugan, of course, for these wonderful case studies, Dr.
Speakers.
Divya and Dr. Swati. It was wonderful. It was very enriching. So thank you so much, everyone, who joined us today.
Probably it is more tasty because both of them come from Kaveri.
Oh, yes.
Very tasty, I think.